So hi, and welcome back to day 3 of the Global Health Reciprocal Innovation Workshop. And we are in the home stretch. Can you go to the next slide, Arena? Thank you. The agenda today will begin with a summary of the ideas that were presented for the past 2 days. And then we will hear presentations from 9 of our colleagues about their institution's interest in global health reciprocal innovation. And we'll end the day by discussing the next steps and outputs from this workshop. We have some wiggle room, as I indicated this morning in the agenda, so we'll try to have some Q&A at the end of all the presentations from the roundtable. In any case, please, as you have in the last 2 days, put your questions in the chat so we can have easy access to them following the presentations. As you know, a focus of the first day was on models, and we accumulated a lot of information about the models, grant types that were used to conduct the research that was presented during panel 1. And in the breakouts. In particular, the first 3 grant mechanisms listed here include the concept of planning and pilot grants to flesh out many aspects of GHRI that we discussed, which can make the reciprocal innovation project successful, such as negotiating partnerships agreements and getting the correct stakeholders involved. We also heard some new and I think pretty exciting ideas that some PIs have been experimenting with of pairing trainees from global and US training programs such as K43 and K23 trainees and T32 and D43 trainees and probably many other mechanisms. We heard about holding GHRI conferences where trainees can talk about their research. Next slide, please. We came up, I think, with some compelling opportunities presented through GHRI research, reasons that you would want to use GHRI research, such as gaining new pools of investigators, learning new things about your intervention, for example, how it can be used and what issues it can address. We heard about improving your intervention with information from its implementation in other contexts, and the fact that you can integrate research involving global public health campaigns is particularly compelling in light of COVID. Next slide, please. Barriers to GHRI research were many. Overcoming the we know best phenomenon, convincing stakeholders to try something new and developed in an LMIC can be difficult. Technology issues were described as huge. And then there were the language barriers, which affect many areas of research and GHRI research also. There is also the fact that national and global programs and funding are siloed, which makes funding for GHI research much more difficult. Next slide, please. We need to discuss if implementation science can be used for GHRI research. There are certainly many IES frameworks, including ones which address equity, which have been or could be applied to GHRI research. We heard about the use of the adapted framework, about a dissemination and global learning framework, and others. And some of these frameworks still need to be tested in GHRI research to be validated. Next slide, please. We heard about using lessons learned, the suggestion of using lessons learned from implementation science to develop the area of GHRI research. Next slide, please. We learned about some methods such as human-centered design to include stakeholders from the start, which could also be used for GHRI research. And we also heard about tools such as an MOU structured to ensure equitable research partnership that could be important in GHRI research. Addressing the importance of equity and attribution was agreed to be central to GHRI research. Next slide, please. And finally, there were many, many comments and suggestions about the funder's role in GHRI research. These included ideas about incorporating equity and attribution into the grants, a suggestion that any mechanism used for GHI research should include support for formative research and cover fees for legal and IP services, and many other suggestions. Next slide, please. We will discuss some more of this following the roundtable presentations when we determine how to use publications, webinars, toolboxes, online databases, and perhaps conferences to disseminate information about GHRI research. And this leads us appropriately to our roundtable presentations from NIH, ICs, and other funders. The objective of these roundtable presentations is to learn more about institutional interests in GHRI research, including any programs that support this type of research. We're a little bit ahead of schedule. I know that Diane and Anna are here. So maybe we will start with them and then go on, unless people have comments about the things that I've mentioned. There are some comments in the chat. And our insight, Janet, you're here? You want to just say what you were talking about?
Sure. I just, when you were mentioning the models, I realized that I didn't talk about that before. And I just, we have one of these launch D43 programs along with University of Maryland, Baltimore, and others, which is one of the few mechanisms that actually trains both US and MIC trainees in the same program. And so I was just thinking about how those programs are another great model or starting place for GHRI. And our program has a very, really trying to make sure the mentorship for each trainee is coming from both LMIC and US mentors. And then we have these scientific working groups where the mentees across settings work together. So that could be a platform for more GHRI, was just my thought.
Yeah, no, that's great. I mean, the more opportunities that we know about, the better off we are. Thank you, Janet. We'll capture that. Okay. Diane, if you're ready, and Anna, unless someone else has something else to talk about, I think we'll get started.
Okay. Should we just get going?
If you don't mind, that would be great. So Diane Roush and Anna Ordonez. Thank you. From the National Institute of Mental Health will give us some background on their IC and their interest in GHRI. Over to you, ladies.
Great, thanks. So I'm going to talk a little bit about the Division of AIDS Research, supported research around, and what we've been doing around reciprocal innovation. So our division supports basic and clinical neuroscience to understand and alleviate the consequences of HIV and the CNS. We do basic and applied behavioral science research to prevent HIV transmission and limit morbidity and mortality among those living with HIV, and translational and implementation science research to maximize the impact of the expanding pool of effective interventions to improve prevention and treatment outcomes. So most of the areas in the research that we funded relevant to reciprocal innovation have been around the behavioral and social science area. Early in the epidemic, we supported a lot of research targeted to understanding the factors that put individuals at risk for acquiring HIV, and then developing interventions to prevent it. And once ART came into the epidemic, we supported research to improve uptake and adherence to treatment strategies. As we made progress domestically, we began to adapt our effective interventions in both prevention and treatment into LMICs. And this was sort of an organically moving forward natural progression. So as these interventions were being adapted and implemented in LMICs, new approaches emerged that worked well in those countries, and but also could be beneficial domestically. So not just entire interventions, but specific components of those interventions that worked well to do better engagement and have more effect. And these could be adapted. Now, we could see that these could be adapted in certain areas domestically to enhance the implementation strategies here at home. So these included new ways of doing things like community engagement, such as setting up information booths at public markets, task shifting approaches, including the development of new cadres of healthcare workers to perform specific activities, and many others. So as we've heard from this meeting, there are a lot of lessons learned from reciprocal innovation and emerging interest in expanding this concept. And the many models presented over the past couple of days are great examples of ways to move forward in this area. So we want to think about this, how to more proactively take advantage of the benefits of reciprocal innovations and expand our capacity to do that. So I'll turn it over to Anna Ordonez, my NIMH colleague. She'll give a brief overview of the interest of the NIMH global team in reciprocal innovation.
Thanks, Diane. So as Diane mentioned, in addition to all the efforts within the Division of AIDS Research and the Center for Global Mental Health, which is in that division, the NIMH also has a global team that has been thinking about reciprocal innovation. The term we've been using is reciprocal learning, but I think in general, it's the same concept, kind of like Yolanda's team has been thinking about global learning. And what we've been doing, or where we started, was actually looking at some of our incredible researchers who are within the global mental health community who have been doing this for some time and really trying to highlight, I'm sorry, their work in reciprocal learning. So we started off by, looking for examples and trying to highlight some of these efforts to bring this to the attention of the global mental health community and emphasize its incredible value. And I think in working with the Center for Global Mental Health and all of the global mental health efforts within NIMH, there's really been a focus to continue to highlight this, try to encourage our investigators to talk about the reciprocal learning experience, in addition to, reporting on the outcomes of their research studies, to also talk about all of these different nuances we've discussed over the last few days within the whole experience of the reciprocal learning and how this collaborative effort has occurred. And as we're moving forward, we're trying to really encourage more reciprocal learning, as in the studies that are being funded, and encourage our research community to continue to present this part of the process as something important within their research studies. So again, really trying to highlight why reciprocal learning is so important, for everybody, and trying to get the word out there more. And I think that was part of, that was certainly part of the discussions in our small groups is, how do we get more people to know about this, to learn about each other's work, and to be able to collaborate and leverage some of these incredible innovations in different settings. So I think that's our general idea, is to try to, get the word out, as well as trying to encourage more of this within the research that gets funded. And we've done that so far by presenting. We've had presentations at different academic meetings where we're really showcasing and highlighting some of these reciprocal learning efforts, as well as trying to now put some publications out there, encourage our investigators to talk about this within publications. But we know that we need to spread the word in lots of other ways as well. And I think we got a lot out of thinking about what other venues to be discussing this in, and basically trying to discuss it in as many venues as possible when we're talking about global mental health research.
Thank you, Diane, and thank you, Anna. We'll take questions at the end, but if you have one that pops up, just put it in the chat, please. And our next person to give us a talk is Erica Rosemond from the National Center of Advancing Translational Sciences, NCATS, as we finally call it.
Thanks, Linda. Good morning, or wherever you are in the world. Hello. I want to thank the organizers for the invitation and the such a comprehensive agenda over the last couple of days. It's been really interesting hearing about some of these things. So I'm joined by my colleague, Rashmi Gopal Shrivastava, who represents NCATS on this planning committee and the interests and perspectives in this space. I'm Erica Rosemond. I'm the acting deputy director for the Division of Clinical Innovation, as well as the branch chief for the CTSA program. The CTSA program is administered by the Division of Clinical Innovation, whose mission is to innovate in clinical and translational science. The CTSA program comprises a national network of over 50 medical research institutions and their affiliated partners and institutions. In fiscal year 22, Congress allocated a little over $600 million for this program. The CTSA program encompasses the full spectrum of clinical and translational activities, including health disparities, as well as rapid response to urgent public health needs and other relevant activities. The program has greatly contributed to NIH's response with the opioid epidemic and the COVID pandemic, deploying infrastructure and expertise in these spaces to rapidly respond to these health needs. A CTSA hub, or our academic medical research institution, is designed to integrate a research and training environment for clinical and translational science, catalyzing the development, demonstration, and dissemination of methods and technologies that dramatically improve efficiency and quality across the translational research spectrum. As presented during this conference, the Indiana CTSA has demonstrated this commitment to clinical and translational science through their Global Reciprocal Innovation Program. This is really seen as an exemplar program of the types of dissemination and implementation activities that CTSAs support to innovate approaches to identifying, understanding, and developing strategies for overcoming barriers to the adoption, adaptation, integration, scale-up, and sustainability of evidence-based interventions, tools, policies, and guidelines. Information tools and interventions deemed efficacious within clinical or community-based trials need to be made readily available for adoption and implementation. And we see reciprocal innovation as key in this space. The methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve the impact of population health are needed. We're aware that the Indiana CTSA is effectively disseminating the results of their Global Reciprocal Innovation Program here and to other CTSAs, and we hope we'll be able to report on additional programs when available. I want to thank you for the opportunity to contribute to this workshop. Thank you.
Thanks so much, Erica. That was great. Okay. we are into the next presentation by Tenchia West and Alpha Patel Larson. Tenchia and Alpha are from the Health Resource and Services Administration, or as we call them fondly, HRSA.
So thank you, Linda. Thank you, everyone. So again, Linda gave a great introduction of us. So we're the Health Resources and Services Administration. We always like to call that out, or HRSA. And my name again is Tenchia West, and then I'm the lead of our Global Health Engagement team in our Office of Global Health. And then I'm also joined by Captain Alpha Patel Larson, who is a senior advisor in our office. So we wanted to share first a little bit about our agency and then get into some of the bidirectional learning that we promote and are interested in. So first of all, we are an agency within the U.S. Department of Health and Human Services. We support a broad range of programs, and that includes those that are geographically isolated or medically vulnerable. And so I want to emphasize program deliveries, because we do that for people with HIV, pregnant people, mothers and their family, people that are low income, residents of rural areas, American Indians, and Alaska Natives. And HRSA is also one of 7 U.S. government departments and agencies implementing the President's Emergency Plan for AIDS relief. We do that. We also do multilateral representation and bidirectional sharing with other countries to improve health outcomes. And so, again, I want to emphasize we certainly have an interest in reciprocal innovation, or what we consider bidirectional learning here. But most notably, we funded the bidirectional lessons learned along the HIV treatment cascade. And that was a white paper that focused on Ryan White HIV/AIDS program, as well as PEPFAR. And what we wanted to do was be very meaningful about understanding bidirectional sharing between the Ryan White HIV/AIDS program and PEPFAR. And this was using a multimodal approach to develop and understand best practices and lessons learned, both from our domestic side as well as our international HIV-funded HIV initiatives. And then in 2018, PEPFAR made a direct request of HRSA to support a bilateral exchange of HRSA-supported HIV treatment programs. And this was PEPFAR sites that needed the most improvement. And in response to that, we created the PEPFAR HRSA Skills Sharing Project, which was initiated. And it was intended to share skills and lessons learned between selected PEPFAR supported sites and HRSA funded clinics in the United States through the country's Ryan White HIV/AIDS program. This was initially launched in Uganda and Jamaica, and is continuing in 4 additional countries in fiscal year 23. So the Minister of Health in Uganda and the existing Ryan White providers are seeking to incorporate this type of bidirectional support outside of PEPFAR going forward, and relying on the expansion of their ECHO platform to leverage best practices for complex case management to save lives in various areas of the real world, including here in rural United States. So further, HRSA developed the best practices compilation in October 2021. I had the opportunity to lead up that design in our HIV/AIDS Bureau, and it used that implement science approach to examine best practices and models to ensure that we had real world HIV intervention strategies that can be easily adapted in other settings. And then most recently, I would say in 2022, HRSA launched this Global Health Forum. And this was, again, like others, to find a venue to showcase our global health initiatives through a virtual webinar series. And the focus is on emerging health issues and promising practices. Our Global Health Forum aims to foster a bidirectional community among federal staff and domestic international subject matter experts. And we really want to address a range of global health challenges and domestic issues as well. And I'm excited to say our first webinar was held in July. And this was a really, really bi-directional collaboration, if I may say, between our HRSA Maternal and Child Health Bureau, the Office of Women's Health, the World Health Organization, USAID, and we explored respectful maternity care principles, inequities, and equalities. We really wanted to look at maternal health care strategy and help inform maternal health programming by highlighting stories in the field and implementation on the ground. We also examined HRSA Global Maternal Health Program supported through our PEPFAR program with a specific example from our Zambia initiative, which is a historically Black colleges and university program implemented by Meharry Medical College for a one-stop shop for pregnant and breastfeeding people living with HIV to ensure healthy pregnancies and timely postpartum care along with addressing infant health together. Our next Global Health Forum is actually today, and it is a collaboration between our Border Health Work Group and the Office of Global Affairs, as well as PAHO, or the Pan American Health Organization. And we will be focused again on lessons learned during the COVID-19 pandemic to improve health outcomes in primary care, but also looking at how this impacts a skilled and diverse workforce in the Southwest border and the United States. Moving forward, we really hope to establish a bi-directional work group and consider quarterly lessons to help solidify subject matter expertise, but also institutionalize our ongoing efforts. And I heard that a lot here in this presentation. With the Department of State's new strategic direction under PEPFAR, we are looking at ways to sustain investments globally across stakeholders to demonstrate how integration of HIV services into primary care, the use of various cadres such as community health workers to expand access to high quality services in a timely manner, as well as the importance of universal health care to address global public health threats is needed in the United States just as much as elsewhere. So we really appreciate the opportunity to speak with you today. It's been such a great learning and really actually inspiring. And we really hope that we can talk more with you about the dissemination of these efforts and how we might have impact and combine efforts and collaborations moving forward. So thank you again, Linda, and thank you to all the presenters.
Linda, you're muted.
There were sirens outside, so I didn't want to, I didn't want everybody to hear that. Alpha, do you want to say something? Add something?
My apologies. I still have not recovered from my voice. So Tenshia was able to speak on behalf, but I am available to answer questions, which I put in the chat. Thank you.
Great, thank you. Tenshia, also, can you put a link to your webinar into the chat for everyone?
Oh, sure.
And also, I don't know if you can share the white papers that you mentioned.
I can.
That would be fantastic. Thank you.
Wonderful.
Okay. Wow, we're getting a lot of information. Thank you so much. Melanie Bacon is from the National Institute of Allergy and Infectious Diseases, now known as the Tony Fauci Institute by everyone, but what we call it is NIAID. Melanie.
Maybe they'll change the name after his retirement at the end of the year, make us officially the Tony Fauci Institute. But so this has been really interesting for me because this has really been a great couple of days and really a learning experience for me more than anything else. I wanted to say I would have an ah moment, but I had like a long series of ah moments. So I was trying to figure out where this really does best fit. I think we have a reciprocal innovation work sort of fit in a lot of different places, but not specifically earmarked, not identified as such, which makes it sort of interesting for me to look at it and try and make it a more sort of organized approach here. So as I was looking, and I was thinking, okay, we have to think about awareness, what's being done, what are we learning from them? Why does it work? And how do we find those things out? And so we know that a lot of this for us is based on research publications. It also may be PR and marketing, but I also think that the training and the collaborative global teams that we have out there now is a huge source of learning what's going on in one part of the globe that could be translated to another part of the globe. So then the next question was acceptance. And I think it was important to think about acceptance on different levels, acceptance in the scientific level, acceptance on the program management level, and acceptance in the community or population level that was going to be benefiting or taking advantage of these new or translated adapted innovations. So I think those were all very important. Those things sort of happen. I guess we all thought those things sort of happened prior to it coming to the research and being ready to sort of to do a research project. But now I see that it's really something that needs a lot more attention. I liked looking at the implicit bias and things that have to do with acceptance. And I think that that's work that's really important. Then it comes to the adaptability, whether it can be translated, what does it take to translate it? How do you maintain those critical elements when you're translating something to a new environment? And, does it maintain its effectiveness? So community involvement, local control, all of those issues are involved in this. And those are things I think we have to think about in the research process. But then you have to come to the avenues, how you're going to do it, what mechanisms are there. We have a number of mechanisms, investigator initiated, sometimes specific requests for things where I think this could potentially fit, but it's not a program requesting this. I will say, I think we're becoming more aware. We are involved a lot with PEPFAR. We've done a lot of implementation science with PEPFAR over the last 10 to 15 years. And I think we are learning from them as we go. And I know that in our last year, we put out EHE FOAs, the one in particular, the multidisciplinary treatment approaches to end the EHE, the epidemic was, the end the HIV epidemic was specifically said, we encouraged people to adapt programs that had been proven successful in other environments, such as global or PEPFAR programs, to work them in the United States to see if they could help us in the United States. I like the idea of frugal innovation because I think it's something we desperately need as we try and continue to figure out how to reach the last groups that we can without further straining the systems. So the question really is, how do we activate the field to take advantage of the mechanisms that exist? And how do we make it more clear that those kinds of research studies are welcome, I think. So, and then the question, which maybe I need some help from you still, is to try and figure out the placement or that you would need to think before you could submit an application. Is this new? Is this considered a new thing? Are you trying a program or an innovation that's sort of out of scope, or I think we would call it off-label if it's a drug. We've used the drug for this and now we're going to use it here. How does that fit in? Does it come in as a new investigator-initiated clinical trial? Does it come in to an EHE announcement when those are going out? There's a lot of different ways that these can be done, but this is something that I would say within our institute, we haven't thought very specifically about reciprocal innovation. And this has been very helpful for me because I think we can do that now. I certainly feel like I have much better grounding on exactly what this is, and hopefully we can have discussions.
Thank you, Melanie. That was wonderful and informative. Next up, we have Rear Admiral Timothy Haltz from the NIH Office of AIDS Research, where he is the Deputy Director. Rear Admiral Haltz.
Hi, Linda. Thanks so much.
Hi.
I'm just trying to get my lighting correct. This
Good
rain
luck.
morning.
Always hard.
Yes, nice to meet you, and thanks so much for the invitation. And I'm joined here today by, at least what I can see, several other of my colleagues that I work with, Drs. Glenshaw, Geist, and Tomich from the NIH Office of AIDS Research, NIH OAR. Linda, I just wanted to give a personal thanks for your, at least this, I wasn't able to join you on day one, but from what I saw, the slide sets, you gave an example of the Polela Community Health Center and the work of Jack Geiger. And before that, the Karks, who brought this idea from Israel, actually, and then to South Africa and built a community health center model that then Dr. Geiger brought back to the US and built in Mount Bayou, Mississippi, and Columbia Point. And I actually was never able to visit the Mount Bayou site, but I worked at the Columbia Point Health Center, the network of health centers that included Columbia Point. And actually, Dr. Geiger was a mentor of mine for many years.
Oh, wow.
And he often, in fact, he was the one who first encouraged me to go to South Africa and learn, take lessons learned from South Africa. So I was glad to see that he lived a very long life and shared his lessons well into his 90s. And so that was encouraging to see. And he often spoke about bidirectional learning. And so it's really a pleasure to be here today. The NIH Office of AIDS Research is an office within the Office of the NIH Director. And we coordinate the scientific, budgetary, legislative, and policy components of HIV/AIDS research across the agency. And importantly, we're responsible for the annual allocation of the HIV/AIDS research funding budget, which is about, it's a small piece of the NIH budget, about 7%. So it's about $3.2 billion every year that we allocate to various ICOs with active HIV research portfolios, of course, which includes NIAID, and NIMH, NICHD, and NCI, and many others. So our mission is to advance research to end the HIV epidemic, improve health outcomes for people with HIV, and ensure that the funding that we get from Congress is directed at the highest priority areas to facilitate maximal return. And we really can categorize our activities in four of the 4 C's, the 4 categories of the 4 C categories of catalyzing, coordinating, communicating, and convening. And we do this not just across NIH, but across many other government agencies, which I see here on this call, including CDC and HRSA, and academia and community and non-governmental organizations and the activist community. And we do this through diverse collaborations and partnerships in support of the research agenda and the strategic plan for HIV and HIV-related research, which we help coordinate. We work also very closely through with the White House and through the National HIV/AIDS Strategy, which just got released last December from 2022 to 2025. And this is, of course, a national plan, provides stakeholders across the country with a roadmap to accelerate efforts to end the HIV epidemic, and has really bold targets of reducing HIV infections by 2025, and then a 90% reduction in infections by 2030. And I won't go through these plans; they're readily available on the internet. You can see the targets. We also work through, as was just mentioned by Melanie, the End the HIV Epidemic Initiative, which has an initial focus on 48 counties, started 3 years ago, as well as 7 states and Washington, D.C. and San Juan, that had 50% of the new diagnosis a few years ago. And they have also 4 pillars to achieve their goals of reducing HIV diagnosis in those areas. So first, some general points that I've observed about the HIV research work that I've seen and been involved in. And I think this is probably true for many other areas, but we found that in HIV research that innovations and technologies that have been researched, developed, and implemented in low and middle income countries, as many call LMICs, can be adapted and adopted to address similar challenges in the US. And particularly social and behavioral factors like stigma, racism, poverty, food and housing insecurity. And Dr. Geiger would often tell the story about food insecurity in Mount Bayou and how he used to prescribe food as medicine there. And these are still particularly significant and important to address as people live longer with HIV. And these are areas of research common between high-income countries and low-income countries, for sure. HIV research advances have crossover benefits, such as the development of vaccine platforms and strengthened health systems, and evidence-based prevention and treatment strategies and lessons learned in every continent have the potential to benefit all people, at least in our field, who have HIV. And this is why collaboration and international partners are so important, because it can lead to bidirectional knowledge exchange that globalizes all the benefits. And just to talk about a few, I'm sure maybe I'm going over time, but I saw that we started sort of early. The HIV/AIDS research portfolio has a significant global component, about 20% of the overall portfolio, and 3/4 of that is investment focused on building research capacity in countries that receive PEPFAR assistance. There's over 100 clinical research sites in 18 countries, and they've over the years, there's so many examples of how the NIH HIV research investments have helped develop and test effective tools and interventions to improve diagnosis, treatment, and management of HIV and the comorbidities and complications that increase the lifespan and quality of people with HIV. That includes advancing prevention and treatment of HIV in infants, children, adolescents, pregnant women. I won't go into the examples, but particularly like the early studies of AZT and prevention of mother-to-child transmission are lessons learned globally that we, of course, brought back to high-income countries. It also includes promising microbicides that block HIV transmission and some with dual purpose, for example, HIV protection and contraception, that are applicable to women everywhere. Studying optimal agents and the time to begin ART and to reduce morbidity and mortality. And I can't go through this talk without mentioning the treatment as prevention proven through the HPTN trial 052, which had many, many sites, international sites around the world, that demonstrated that ART given as soon as possible to an individual diagnosed cuts the risk of that virus being transmitted by over 90%. And now that concept of treatment as prevention has really become the centerpiece of stopping HIV transmission worldwide, both in in high-income and low-income, middle-income countries. Some really interesting examples of bidirectional learning and knowledge sharing have occurred in sort of the mobile and social media, revolution that we've all lived through in the last several decades. And I've seen that in rural clinics in Africa, and it's provided such an amazing setting to study how best to provide diagnosis and treatment through these small mobile devices. You go to the far reaches of some of the most rural towns and villages in Africa, and you'll find people have cell phones. They're still living in temporary housing or unstable housing, but they've got the communication device, and there have been tools developed using mobile technology. There are interventions, for example, particularly in Kenya and Uganda, for treatment and treatment adherence, improving adherence, and also to help people overcome substance abuse disorder with HIV that have been adapted for use in the United States. There's also, I've heard mention, I think several speakers ago, maybe from HRSA, about community health workers. And of course, going back to Dr. Geiger, that was his particular emphasis early in his career, and bringing those lessons learned about community health workers. And now we have community health workers that work on HIV care, and that was pioneered by NGOs in South and East Africa and the Caribbean. And in fact, now some of those lessons have been integrated in many community-based programs in the US to prevent, treat, and monitor HIV infection. Well, what are we doing now? Just if I'll take another minute about some really exciting areas in diagnostics and clinical monitoring. We saw in the International AIDS Conference this summer that this is a programmatic gap area, but we are trying to support point of care technology research grants, working with some other institutes at NIH, for example, NIBIB and NIAID, that are hoping to build important and improve the development of rapid at-home diagnostics for HIV and as well as other STIs. And so we're hoping to convene a workshop early next year on the state of the art of technology in this field, disseminate the recommendations, and of course the plan would be to share those successful models learned in LMICs to be adapted in the US. And then may have been mentioned before, I see several colleagues here who've worked on a particular interest of ours, which is HIV in pharmacies. We're working with our colleagues in NIMH to leverage the lessons learned from pharmacies and their successful experience with COVID-19 to advance HIV prevention, treatment, and care. And I know from the years that I've spent in LMICs in Africa and in East Asia that pharmacies play an important role in healthcare for people. Often they can't get to a clinic, but they can go to a pharmacy. And so we know that they provide a potential model to explore opportunities for testing and particularly prevention, like PrEP delivery. And so some of those lessons learned, hopefully, we'll get a better handle on, and hoping to convene a meeting early next year to assess where we are with that, what future research opportunities we have in pharmacy-based prevention, treatment, and care. And so this is an ongoing, particularly ongoing field that we are hoping to continue to work in. And I appreciate the chance to speak to you today. Thanks so much.
Wow, that was amazing. Thank you so much, Rear Admiral Holt. That was very invigorating to hear all of that. And also,
well, in HIV research, there's always a lot going on.
Yeah,
definitely.
Yeah, and there's a lot of room for reciprocal innovation, I believe. So thank you. Okay, now we hear from Flora Katz from the Fogarty International Center, my home. Flora, are you there? Yeah,
I am there.
Welcome.
Thank you, Linda. So I'm Flora Katz. I'm the Director of Extramural Programs at Fogarty. Since Fogarty is the host of this, I assume most of you are familiar with us, but just to reiterate, we are the smallest IC or institute or center at NIH, and the only one that specifically has a mandate to work in global health. Really importantly for this discussion, our mission is to build capacity in low and middle income countries, and we do not support domestic research. So how does this fit into this reciprocal innovation ecosystem? We have a number of extramural programs, all of which are solicited by specific FOAs or funding opportunity announcements. Most of them are for training of LMIC scientists, either through training programs, fellowships, or educational programs. But we do have a growing number of small exploratory grant programs, HIV stigma, HIV and non-communicable diseases, M-Health or mobile technologies in health, and brain specifically, as well as a smaller number of larger grant programs, particularly through PEPFAR and Common Fund funding. So while we've never had a program that specifically solicited applications for reciprocal innovation, a number of our projects or projects that we've contributed to later resulted in those type of programs supported by other funding agencies. You've heard 3 examples already in this workshop. One of them was Janet Turin on stigma and HIV. The talk on the friendship bench, we contributed to early work on that through Dixon Chibanda. And Deborah Litzelman mentioned the seeds of We Care in one of the FIC training programs in Kenya. So we are contributing to the base. We also have other examples through our research programs that act as sort of portals for other ICs to contribute. So we collaborate quite widely at NIH. One, I think, very nice example is a grant through our brain disorders program to Benjamin Wharf, who developed an alternative to using shunts for hydrocephalus in children in Uganda. The shunts often fail, and then you have emergencies later with high risk. And he developed a non-shunt method to treat hydrocephalus. That grant was supported largely through the National Institute of Maternal and Child Health, of Child Health. And that's now in use in a number of places in the US, including at Boston Children's Hospital. And we also have a number of examples in our mobile technologies program. As Dr. Holtz just mentioned, it's a very ripe area for transfer, and particularly not only apps, but some diagnostic devices that have been developed are already being transferred or have been. So, I mean, I think the important thing for us is we are seeing, and it's serendipitous, as Linda says to me, it's serendipitous and not intentional. But we have seen that the exploratory work we do and the hopefully equitable collaborations and partnerships that we foster through our programs become the seeds for opportunities to do reciprocal transfer. And I think we're using this this meeting to better understand the concept and what our role might be in making this somewhat more intentional, as we do think it's a very important area. So I think I'll stop there. Thanks, Linda.
Thanks very much, Laura. That was great. And next up, we have Dr. Divi and Dr. Michael Osenden from the National Cancer Institute.
Good morning. Dr. Linda, can I share some slides, if you don't mind?
Sure.
So do you see my slides?
Yep, we see them.
Excellent.
Thank you.
My name is Rao Dibi, and with me, I have Dr. Miguel Osenden, and our focus is on keeping pulse on breakthrough technologies that have the potential to make a difference in the global health, and particularly encouraging the affordable cancer technologies development. I'm sure everyone can benefit from the affordable cancer technologies. Through here in the US as well as in the low and middle income countries. We have several low resource areas in the US, and our goal is to develop the technologies that can make a difference. So we have several programs at the Center for Global Health that encourage the technologies development and adaptation, and also implementation in the global health. And we continuously encourage the investigators to have the bidirectional exchange of the ideas, information, and technologies, and also the lessons learned during the implementation while addressing the barriers and challenges in the low and middle income countries to bring back and to the low resource areas in the US. So one such program is the Affordable Cancer Technologies for the Global Health, and where we are trying to adopt the existing technologies that are being developed in the high income countries, and the repurpose and re-engineering those technologies for the low and middle income countries, where the technologies will be much more affordable for the LMICs. And this particular mechanism actually encourages the multi-PI participation, and the investigators from both high-income countries as well as the low and middle-income countries are required to be the PIs or the key personnel, and they are supposed to contribute intellectually to the development of the proposal as well as performing the research activities on the projects. And they are encouraged to own the intellectual property, both LMIC as well as the HIC, and not just only the high-income countries investigators. And so the As I said, it is for adopting and applying and re-engineering and validating the technologies that are existing to develop into new modalities that will be useful for the LMICs. And they are supposed to focus on the preventable and the treatable cancers in the LMICs. And we continuously, as I said earlier, we continuously encourage them to bring back the knowledge from the LMICs to the high-income countries. And as I said, we encourage them to own the intellectual property on both sides, not just only the high-income country investigators, unless the technologies are being completely developed here by the companies, and then where there is a little opportunity for the LMICs to own the intellectual property. And so we take into consideration the local context and the local health systems, and then all the issues associated in the LMICs. And then, as I said, we adopt the existing technologies and to address the preventable and treatable cancers. And so it's supposed to have the oncology, engineering, business, and the global health expertise. And while taking the consideration of the local context and the knowledge and then the ecosystems in the LMICs, and also the cultural practices and social practices in that part of the world, and also the economic conditions, so that the technologies can be really affordable in that part of the world. And so the knowledge can be brought back here. And the same model, we have another mechanism in the SBIR, where the technologies that are developed by the companies that are involved in the global health, they can bring back that knowledge as well as the lessons learned during the adoption and then validation, robust validation of these technologies in the LMICs. And then repurpose those technologies or re-evaluate, revalidate those technologies in the low resource areas in this country, and implement those technologies both in global health as well as here in the low resource areas. And we use different the SBIR mechanisms from R41 to R44 for this purpose. And for the global health, we are focusing mostly on the cervical cancer, colon cancer, colorectal cancer, and then esophageal cancer, and also the oral cavity cancers in Southeast Asia as well as in other parts of the world, and also on the HIV-associated cancers. So one success story in this the efforts is screen and treat modality for the cervical cancer control. So we developed the technology for robustly validated the technology for the cervical cancer screening, HPV DNA diagnostics, and it was validated in Kailitsa in Cape Town, and with partnership with the non-government organizations which subsidize the cost of the screening or even covered entire cost of the screening. And we screened so far about 20,000 subjects and treated around 3,000 subjects in that part of the township, the Kailitsa township, Nelson Mandela's township. And the company has brought back that knowledge, the validation knowledge in that part of the world, where they can provide the treatment using the HPV diagnostics as well as the thermoablation as for the treatment within 60 minutes in the single visit, where we could really reduce the loss of the patients during the follow-up and make the difference significantly in a short amount of time. So they are bringing the knowledge here and then trying to validate and then implement the technology in the low resource areas in the US. And so one other program that we have at NCI that's maybe more relevant to this particular forum is the dissemination space, implementation and dissemination space, where we are trying to encourage the investigators to identify and understand and also develop the different strategies for addressing the barriers by adaptation and then integration and scale up of the sustainable evidence-based interventions, tools, technologies, policies, and guidelines. And in addition to that, they learn the lessons and then see what is working, what is not working, and what are we doing the war diagnosis and war treatment, and if they are not effective, can we stop them? So we are trying to learn from that exercise, and then we'll be bringing back that knowledge here to address the health disparities in the low resource areas in this country. And so this also encourages the dissemination and implementation research methods development, and also developing the frameworks and measures. So this is another mechanism the investigators can probably use for the reciprocal innovation. I'll stop here, and then I'd like to invite Dr. Miguel Bosandan to say something.
Yeah, thank you for your presentation. I think you covered the most that we are working here. I want to mention that I work in technology development. So for me, when I talking about innovation, immediately my mind go to technology development, reciprocal innovation, or how we bring this technology. In this webinar, I learned that it's a lot more than just the technology, right? I can say that we have a broad pipeline trying to cover all the stages of the technology development, and those that pipeline, those populated with funding opportunities, can help to investigators to develop technologies for low and middle income countries. And in some way, that technology can be transferred back to underserved populations in the United States. So we have for early development technologies, they have the bioengineering research grant is focusing basically in implementing bioengineering principles more than the scientific principle, right? So it's not really hypothesis oriented like the regular R01. It's more tailoring to bioengineers that they want to produce applications and develop their projects using the common mechanism. So we have an R21 that is for early development, and then we have a R01 mechanism they call the bioengineering research grant that also allow the validation of these technologies. And then more advanced than that, when the technology is validated, right? So if we think about SBIR mechanism, phase 1, phase 2 is the validation. Then beyond that, we have the academic industrial partnership program, where we want to further develop this prototype that they are developed in the previous FOAs, right? So we talk about academic prototype. Now we want to develop a pre-commercial prototype. So that process, they call translation, we develop this FOA, but we ask the investigator to partner with industry. So industry can help them with the FDA approval or anything that they need that academics usually are not that familiar with, so they can move the technology forward. And those mechanisms, so we have some applications that they have a potential for reciprocal innovation or reciprocal technology translation, we call it in that way. So I want to mention a little bit about one of our investigators that developed a histopathology test, right, using regular H&E slide to obtain the same result that we have with molecular tests. So you are familiar with the Oncotype DX, right, to see if women with breast cancer will be benefit with radiotherapy after the hormonal therapy, right? So no everybody qualifies. So we have the Oncotype DX to tell us which patient will qualify. It's around $3,000. I think in low and middle income country they lower the price, so $3,000-$4,000 test. So Dr. Malabushi from Case University, now I think in memory, he developed this test where using the feature and pathology slides, right, the same feature using artificial intelligence, he can actually get the same, sometimes better result, the molecular test. And he developed the test for low and middle income countries where you have the infrastructure, you have the H&E slide, and then he applied this machine learning, and you don't need to pay the $4,000 for the Oncotype DX. So he said, very good. Now he was thinking to, okay, can we use that in underserved population? Here, the doctor immediately said, okay, go to Oncotype DX, the insurance is going to pay, right? But sometimes you have an underserved population where the insurance, you know, a lot of people are not insured, right? The access to the molecular test could be more difficult because it's more expensive. And then you can have these tests in pathologies, like regular pathology. So I think that is a good opportunity to develop this test that can be used back in the United States. So, in all of our mechanisms, right, that we include language about how can we serve underserved populations, right? So we have some language that encourage the investigators to work in global health or in underserved populations. Now, I'm thinking after this webinar, we can include language and those mechanisms where we renew these, the bioengineering research grant, the academic industrial partnership, the focusing technologies mechanism to include language so we can actually encourage investigators to, maybe they're already developing something in low and middle income countries to bring it for reciprocal innovation to bring back to the United States. And I think I will start with that.
And I just want to say one thing. So we have several technologies that are being, they validated and implemented in the, the global health, in sub-Saharan Africa, Southeast Asia, and then China, Mongolia, and South America. And we are able to actually transfer the technologies from one country to the other country much, much easierly in these LMICs, and not that easily able to transfer the technology from the LMIC to the high-income countries. I think it is a big gap. The investigators are not really trying to bring the technologies from the LMICs to here, and but the FDA is not averse to approve the technologies for the high-income countries, for the US. So that's what my understanding is, recent understanding, after they have approved several technologies from the LMICs that were developed for the COVID-19 SARS-CoV-2 diagnostics. And so we have several tests that are under $2, which are actually developed in the LMICs. So that are being marketed here. So it's FDA is not averse to the validation as well as the clinical validation as well as approving those technologies here in this country. That's my understanding. So we can bring back the technologies to address the health disparities in this country. That's what I wanted to say.
Thank you very much. Actually, maybe our job is finished. I'm just kidding, but that's great news, Miguel and Dr. Vivi. That's wonderful. Thank you for all of those opportunities that you have highlighted. Just going to close my window because somebody's mowing. Of course, that always happens. Okay, so now we're going to hear from Vijay Iyengar from AARP. Vijay, thank you.
Thank you, Linda. It's a real pleasure to join you all virtually from Washington, D.C. I first want to thank the NIH, excuse me, and Fogarty for organizing this convening, and I congratulate and thank you, Linda, on your decades-long leadership and public service. My name is Vijay Iyengar, and I serve as the Director of Global Aging at AARP. Founded in 1958 with headquarters in Washington, D.C., AARP is the world's largest nonprofit, nonpartisan organization dedicated to empowering people over the age of 50 years, to choose how they live as they age. Guided by our motto, to serve and not to be served, AARP represents the voice of its 38 million members by championing positive social change through its advocacy, service, and research efforts. While many are indeed familiar with AARP, I'm guessing few are aware of AARP's international engagement. What we do for one, we do for all. A widely quoted saying from our founder sums up our efforts with the notion that we work on behalf of older adults everywhere, members and non-members alike. As such, to echo a sentiment expressed by Dr. Kilmarks on day one of the workshop, we believe that good ideas have no borders, and we actively work to both identify innovations, emerging models, and promising practices from abroad with the intent of bringing them to the United States via advocacy and policy exchanges. As it relates to the focus of this workshop and how the concept of global health reciprocal innovation informs our ongoing mission, goals, and programs of our work, I would best characterize it as tapping into this global to local or global learning framework, themes that were reviewed by the first panel on day 2 of the workshop moderated by Dr. Chandy John. After all, lessons that are learned in, say, rural parts of Bangalore, India, may potentially apply to those in Baton Rouge, Louisiana, my hometown. In the interest of time, I'd like to share a line of work AARP has undertaken that taps into the spirit of the Global Learning Framework. First launched in 2017, AARP's Aging Readiness and Competitiveness, or ARC initiative, maps out how countries around the world are responding to the pressures and opportunities created by their aging populations, and furthermore, identifies innovations that promise a more active, engaged, and productive older adult population in the years to come. Thus far, there have been 3 editions of the ARC that have been released. ARC 3.0, the latest edition, released in 2021, highlights healthcare innovations from diverse geographic, economic, and social contexts that are emblematic of broader trends and promise a healthier and more equitable future for older adults everywhere. At a very high level, the ARC 3.0 report, produced in partnership with The Economist Impact, highlighted 4 key areas where innovation for aging populations is taking place globally. This includes, number 1, increasing access to healthcare services for all older adults. Number 2, strengthening long-term care provision and support for caregivers. Number 3, supporting aging in place through community-centered care. And lastly, caring for older adults in crisis settings. The ARC 4.0 will be launched in the coming weeks with its focus on achieving equitable, healthy aging in low and middle income countries. Focus is placed on the compounding and curtailing forces to achieving equitable, healthy aging, and identifies concrete, on-the-ground solutions from around the world that both high-income countries such as the US and LMICs can learn from. While AARP is relatively new kids on the block when it comes to this topical area, and while we do not support GHI research as canonically defined through the funding of actual programs, we have demonstrated interest and invested the thought leadership towards global learning via the identification, elevation, and dissemination of global solutions that can be applied to local context here in the US. We are passionate and enthusiastic about the potential of leaning more into this area, given 2 data points. In the year 2050, 80% of all older adults will reside in low and middle income countries. And number 2, the COVID-19 pandemic has underscored the importance of building a more sustainable, inclusive, equitable system of care, especially for marginalized communities, such as older adults that have faced considerable hurdles to healthy and active aging. Excuse me. While the vast majority of GHRI examples presented over the past 3 days of this workshop have not focused on healthy aging, there are opportunities for this form of research to have demonstrable impact on the aging community, both in high-income countries and low and middle-income countries. This is especially true given the intersectionality aging has on those areas and disease areas covered during this workshop. We look forward to working with partners already established in this area, both academic, civil society, private sector, and government, who have funded GHR research, and also learning more about existing global solutions to address healthy aging that may prove helpful to those communities in the US. We also look forward to learning how we can catalyze the implementation and testing of these solutions in the US, and how we can collaborate together with those that are here at the workshop. I close by revisiting our governing belief that good ideas have no borders. Guided by this belief, we hope to serve as the connective tissue between multiple sectors to address healthy aging and advance the health and well-being of older adults everywhere. Thank you for your attention and the opportunity to provide AARP's perspective onto this discussion. Over to you, Linda.
You're muted, Linda.
Thank you. That was a great presentation. Very interesting. And finally, our last presentation of the day, one of the places that has intentionally thought about reciprocal learning, or what we're calling reciprocal innovation, is the Robert Wood Johnson Foundation. And Martina Todaro is here to tell us about their programs in this area. Thanks, Martina.
Thank you, Linda. Hello, everyone. My name is Martina Todaro, and I'm a program officer in the Global Ideas for U.S. Solutions at the Robert Wood Johnson Foundation. RWJF is the largest foundation in the country dedicated solely to health, and we make research and programmatic investments that advance our vision for a culture of health. The Global Ideas for U.S. Solutions team sits in research evaluation and learning and serves as an exploratory and learning mechanism to understand how policies and practices from around the world can help us achieve health equity and dismantle racism and other systems of oppression in the United States. We call global learning what NIH and others call reciprocal innovation. And for us, global learning means that good ideas have no borders, and there is much to learn from low and middle income countries and resource-constrained settings to improve health equity in the United States. We have a very, very broad idea of health. For us, it's not just about healthcare, clinical outcomes, and biomedical innovation. We're very focused on social determinants of health and culture, history, power, and other contextual factors that play a key role in promoting health and well-being. We believe that global learning gives us an opportunity to reimagine what is possible, and it challenges the idea that effective solutions that advance health equity in the United States can only be found in like-minded, high-income, Western, capitalist, patriarchal, you name it, countries. You might have come across the blue marble picture from NASA from 1972, which is the satellite picture of our planet taken from space. And that for us is a good metaphor to describe global learning. In our work, we have found that, like those Apollo 17 astronauts, when we look abroad, we begin to see our own country in a new light. And we begin to open up our imagination to new ideas, solutions, and futures. The global team is 7 years old, and during this time, we have made grants on many diverse topics, such as social isolation, climate change, and the built environment. In the past 2 years, however, we have concentrated our efforts on gender equity, sustainable and equitable urban development, and community power. The primary audience of our work is practitioners, city leaders, and funders, as well as innovators who are experimenting with global learning or want to learn more about it. And we also share our findings with colleagues from across the foundation, and we connect them to current or potential grantees to create synergies across bodies of work. You heard from Dr. Yolanda Okbulu yesterday. Hers was a great example of how 5 CBOs and health systems from around the country found inspiration from Togo, Peru, and Brazil to address local challenges. And I would like to share with you another example of what global learning looks like at RWJF. In Bhutan, the collective well-being and happiness of people and planet are valued over GDP and economic growth. People are prioritized in their everyday lives, and this shows up in the fact that the country provides free basic health and education to everybody. There are no billboards in sight, and instead, nature is sacred and enshrined in the Constitution. This is what it looks like when well-being policies are implemented and prioritized in people's everyday lives. Getting to know Bhutan's way of life broadened RWJF's understanding of equity and helped us imagine asset-based, holistic approaches to measuring communities' progress. What if instead of focusing only on economic indicators for social progress, the US also looked at people's sense of belonging, social connection, and quality of life to understand whether our society is getting stronger? Some cities around the US are moving in this direction, from Santa Monica, California, to East Point, Georgia, to Louisville, Kentucky. And a related question we ask ourselves is, what would it take to bring this idea to scale? And that's where forums like these are powerful to find practitioners and researchers that are willing to take on that challenge. I will stop here today as far as my overview of global learning at RWJS, but I invite you all to visit our website and learn more about our global learning efforts in our Blue Marble Gallery, which I will post a link to in the chat, as well as our Reimagine in American webinar series. We actually have a new webinar coming up next month, which will focus on what countries can teach us about community power. And I'm happy to post that link in the chat as well. Thank you for your attention.
Thank you so much, Martina. That was great and very helpful to, I'm sure, our PIs and also the staff here at NIH. Thank you. Well, now if people have any questions, we can take a few questions. If there is someone who whose IC or institution did not get a chance to talk about their programs, now would be the time. And otherwise we will go on to our next activity. You can, raise your hand if you have some questions. And sure, Melanie, go ahead.
Did I need to go ahead?
Did you want to mention something?
No. I don't think I raised my hand. Sorry.
Okay. Sorry.
I will just say one thing, I guess, and that is something that I was thinking about is where the because there are different stages of this research, trying to sort of figure out where this fits and if mechanisms and a focus on this has to somehow be divided up by stages. I know there was some discussion earlier about sort of planning and that kind of thing, and how you fit these into the kinds of mechanisms that we have for funding. And so I just thought that was a point of considering how these fit in these different levels and whether or not they fit into things that we already had that didn't specify reciprocal innovation, but still they fit into what was already out there, or if something specific was needed.
Yeah, I think we might find that we can approach that in several different ways. So we'll talk about that maybe a little bit more. And I'm just looking here. I think that there was one question.
Rajesh has a hand.
Oh, Rajesh, please go ahead.
Yeah, hi, good morning, good afternoon, good evening to everyone. Phenomenal workshop, and just again, kudos to all the organizers. I had two comments, and maybe I'll just do each in turn. One is just following, I believe it was maybe Janet who had suggested leveraging the multi-institutional D43s as sort of a resource for global health reciprocal innovation. I think that's great. And then I would suggest considering other research consortia that NIH has either sponsored or is a part of, such as the DSI Africa Consortium or Network, obviously the historically H3 Africa. There is obviously the GACD Consortium that Josephine was here the first day representing one of the projects funded by European Union, part of the GACD. And I think doing something that leverages all those different networks, whether it's NIH specific or even trans funding body across the world, I think would be great. So just to sort of add a few other suggestions to that. And then I had a second question, I forgot, but maybe it'll come back to me at some point.
Okay, thank you. Anyone else? Yes, Matthew.
Yeah, hi. Thank you so much, Linda. So this is really just a UK, very selfishly, it's a UK question. And I wanted to ask if there are opportunities, perhaps this is directed to Martina in particular from the Robert Wood Johnson Foundation, whether there are any funding opportunities or collaborations that you can conceive of with the United Kingdom around supporting reciprocal innovation. Do you do that already, or are there opportunities for that in the future? That would be great to know from my point of view.
Yes, we absolutely support researchers from abroad. One caveat I think for us is that it's important that the idea or innovation has a clear landing in the United States. So it's not going to be research and learning for benefiting the international partner, but there is a clear path for how this idea could be received in the United States, by whom, and we especially appreciate proposals that upfront identify a partner in the United States that the applicant can bring along in their journey. But yeah, we absolutely fund international partners. We've had a number of grantees in the United Kingdom. We do have some ad hoc proposals that we fund, meaning that we receive a great idea that we feel strongly about funding. Otherwise, as is true for most of the research that we fund at the foundation, there are official calls for proposals that we launch. And we actually have another one coming up in the spring of 2023. So I encourage you all to sign up for our newsletters if you're on the lookout for funding opportunities.
Thank you, Martina. Thank you, Matthew. Janet.
Yeah, I guess my question is for the NCI colleagues, and I was just wondering if there is interest in, I mean, it sounded, what I heard was a lot about technology and treatments and sort of biomedical approaches. And I was wondering if is there also interest in innovations that are more behavioral or cancer care support or other types of innovations that, again, maybe could be developed in a country abroad and then also maybe applied in the US. We're doing some work around stigma reduction around breast cancer, and we're actually doing it in Kenya and Pakistan, but it's been suggested that we could do the same work in Alabama. And so I'm just curious if that kind of work is of interest.
I did show one slide where I have shown the R01, R21, and R03 mechanisms that are trying to do the implementation and dissemination science. So that mechanism is appropriate for you. I think you should take a look at that. And it does allow the kind of research that you are talking about in those mechanisms. And we have other mechanisms in the Center for Global Health. I can send you the links for those, and you can take a look at those as well.
Thank you. Okay, thank you.
We are mostly in the technology space, so therefore I cannot talk a lot about that. And then if you ask me anything about technology, and myself and Miguel can guide you, navigate you through all the opportunities that we have.
Thanks.
In fact, actually, one of the investigators, Dr. Deborah, was showcasing the other day that she was funding through contracts in her project, is actually repurposing the technology for the street drugs that being used for fentanyl and other compounds in Malawi. She's repurposing that one for the chemotherapy quality assurance and quality control monitoring in the different parts of the sub-Saharan Africa. So we funded, basically repurposing the technology for one purpose to a different purpose through our technology program. But we have U54 mechanisms as well as R01 and U01 mechanisms where they are trying to do the more of methods, frameworks, and then models development for the dissemination and then implementation.
Thank you. I see Rear Admiral Halt has his camera on. Did you want to say something, Rear Admiral?
Oh, no, I thought this was the question and answer period, so I turned my camera on.
Oh, it is. Okay, thank you. All right.
I'm still available. The only comment I wanted, and I'm sorry I missed the first 2 days of this, but I'm sure someone has talked about sort of general principles about, this concept that we're talking about, which has different names. But I have to, I just wanted to add for a minute that I think some general principles really have to be about research in particular, but also it applies to program being mutually beneficial, and the work that we do should be appropriate for settings, because we all can give ample examples of things that have been imposed on other communities that were not appropriate, and that interventions should also be applicable, cost saving. And then overall, of course, I've heard some great mention of equity here and addressing health disparities, but we have to make sure that equity is at the forefront of the work that we do. Thank you.
Thank you. Yeah, we have been discussing many of those, all of those issues. So thank you. It's important. Rajesh.
Yeah, hi, thank you so much. Yeah, I remembered my second question. We have been, those of us who have submitted grant applications have traditionally been advised when doing global health work to quote unquote justify US taxpayer money that's being sent abroad. And, so there's generally some text about how lessons learned abroad can be applied back to the US. Sometimes reviewers have said, well, it's maybe not directly relevant. And, even if something shown in Kenya may be related, like a separate, total different study would need to be done in the US. And so I'm just curious, given, the summary of all the different work that's been reported over the last couple of days, just curious from the folks who are at the different institutes represented here today, I don't know, any guidance or thoughts on how to address that issue in the context of potential future grant applications considered.
You probably are tired of hearing from me, Rajesh, but I'll take a stab, and then I'll let someone who's a program officer and talk about it. But in my humble opinion, I think the more we can disseminate information about this field and supply concrete examples of what works and what doesn't work, and put rigorous research into the equation, I think people will start being more accepting. And I also think that we can learn from implementation science and how that field has come up, and people have brought that up. But people, there weren't separate study sections. There weren't. It's true for global also. Really, people need to be educated on these different fields, and once they are, and once it's been shown to be productive and useful and cost effective, then I think we'll have a better chance of really getting this into the fabric of global health. Melanie, did you want to say something?
Yeah, I'm not sure if I totally understood the question, but I think in terms of justifying why you're doing work in other countries and spending US dollars, either addressing the health issues in other countries rather than here. I think it is true that what you do, we learn from, and that we can do it. But I think, at least, I speak just primarily for the HIV research and infectious disease research. We go where it's needed. I don't think we have a very specific restriction on global spending, as long as it can be justified that this is a significant problem, that we will learn from it, but that also, I think global health affects all of us. If you have an infectious disease in Africa, it's going to be in the US soon. We go where the cases are and where it can be studied. So you justify just the need where you're doing the work.
Thank you, Melanie.
Linda, can I just add to that very briefly?
Sure.
I think it's a great question, Rajesh, and I think that in part what's happening at this workshop today and all of these efforts that I think collectively have been done are part of the solution to that question, which is, and to some extent, you know, we've talked a lot about, for example, calling this different things. I think at least one of my lessons learned is as I am using a term, I will try to incorporate some of the other terms that are reflecting a similar concept, because the more that this is a thing that we can talk about, that we can point to, that we can highlight, and that we can now articulate its value in everything we do, I think the more it's going to be woven into, you know, for example, how we conduct research and how we think about our research endeavors. The US is part of the globe, so globally includes how we think about it, you know, in the US and everywhere else in the globe around the world. But I do think the fact that we're really giving it a label or emphasizing what this is, what we mean by it, its value, and that we do that on a regular basis in all the work that we're doing, I think will really help make it really clear for everyone why there's value in investing in these studies around the world, because we all stand to learn so much from them.
Thank you, Anna. Miguel, your hand has been up. You've been very patient.
No problem. Yes, I want to kind of address the two of the questions from Matthew and the other question for, I think, Rajesh, about the reviewers. Do we have, in all of our technology initiatives, we allow foreign components and foreign funding? And in those technology initiatives, you can propose any type of research, right? As long as you have some technology development. And the technology development is very broad. So it could be computational development, algorithms, methods, right? So we can include behavioral science. So there is a division, there is a program in the Division of Cancer Prevention that specifically work with palliative care and symptoms control. So and we have some applications going through this technology development, and they are offering some solutions to control the symptoms, for example, to pain, for example, right? So if the announcements are broad enough, so you can incorporate the project that you want, and you can include a foreign component, or you can apply for foreign institutions. So I have several applications for foreign institutions. Now I want to say the application for foreign institution, the success rate is a lot lower than the application. And I don't think it's the reason that the reviewer trying to see how this technology could be applied to the United States, but it's more like the grantship management. You know, the foreign, you know, the people applying for foreign institution, they don't know kind of the format of the language that the people from United States use. And the reviewers are more common for that, and they're more familiar with that language. And then they kind of, in some way, they become biased. So I do have applications that they work exclusively in foreign countries. They are not in the global health FOA that we develop specifically, but in this general FOA that they exclusively work in a foreign country, and they have very good, they have a very good score, and we're going to fund those applications. So do we have those programs? I want to say that one of my recommendations for all of the grantees, especially the engineers that they call me, I have to, you know, several calls during the week, is you become a scientist or engineer, but also you have to be a salesman. So, and your customer is a reviewer. So it's not as much as how you are going to use the technology in the United States, but how this technology is going to be useful, right? What is going to be the clinical utility? Engineers tend to talk a lot about the technology and forget about, okay, how I'm going to use that. That also the technology have the use, but they don't talk that much in the application. That immediately decreases kind of the value or the strength of the application. The reviewers have hundreds of applications to review, so they give the better score to other one. So one of the things that I see in some of the application, the people don't have the application in foreign countries, and they mention that they can benefit population in the United States. Even in the application, they don't propose to work with underserved population. They still mention the utility. So that the reviewer immediately sees that, okay, so that technology can actually be used in the future, and even though you are not proposing that, then you can mention that that component. So
thank you, Miguel. That's great. Thank you so much. Laura.
Yeah, just briefly going back to Rajesh's question, you know, we at Fogarty don't require people to justify why they're working internationally. It's our whole mission. But, you know, thinking not of the grant, you know, the applicant justifying it to peer review, but think about the funders justifying it to their funder, which is the US Congress. So I just want to point out how important this writing project you're about to embark on is for the whole funding, US funding universe, public universe. You know, it always sounds like hype, you know, to say that these projects can benefit the United States. And then we have a very short list that comes immediately to mind of what we can say. What you've provided, you know, in this workshop and through all of your work are a lot of really compelling examples of how important that can be. So I just want to commend you all for undertaking this writing project. And it'll be, you know, even for the applicants, it'll be a very easy reference, you know, go to this link, you know, when you say these projects can benefit the United States, and then link, you know, link to this collection of cases and the science behind them. So, yeah, thanks.
Thank you, Flora. Diane, you had your hand up.
Yeah, I just have two comments. One is the whole idea of justifying why we're doing work in international settings. It doesn't really come up now at all, and it's changed. 20 years ago, we used to have to do that. For those of us who've been around forever, we used to have to justify why we were doing it. We were spending money in an international site, and primarily it was because it was kind of the work that couldn't be done here effectively, that it could be done better there. And I think that one of the things that's changed that is HIV world, because in the HIV world, it started, the sort of reciprocity started very early on. It wasn't called that. And even now, there's trading back and forth of effective strategies that we're learning in international settings, bringing back here as components of things that we're doing. And it's going back and forth in a very fluid way. I think these days, it's just not being called it or recognized it. So I think one of the things that this meeting is doing, and what the outcome of this meeting is, to really put it in caps so that people really see what's happening and recognize it, and then we can identify a lot more of it that's already going on that it's just not being framed in that way.
Yeah, thank you, Diane. Anybody else? We have 1 minute. Okay, thank you so much, everyone, for your presentations and your really nice discussion of how your IC interprets and can invest in reciprocal innovation and global health reciprocal innovation. It was particularly nice to hear that people really learned more about this field and now feel much more able to discuss it. So I feel like we've made some progress already, and we just have to make more.